Good afternoon and welcome to today's webinar. I'm Paula Murray with HMSA's Provider Service Training Unit. Our topic today is risk adjustment and clinical documentation. If you have any questions, please type them in the chat box and we'll answer your questions at the end of the presentation. We will be recording today's session and we'll post it to the Provider Resource Center on the training page. I'd also like to ask you please complete your evaluation forms and email or fax them back to us. The goals we have today are to help you improve your understanding of why proper ICD-10 coding, risk adjustment, and quality incentive programs matter and how they work together, and how they're going to be even more important going forward with payment transformation. And we'll also discuss strategies for improving documentation and coding. You're probably already familiar with, or at least have heard the term, value-based payments. There have already been a shift from fee-for-service to value-based payments as we see programs such as PQRS and CPC Plus come into play. In PQRS, Medicare has taken its zero-sum changes in funding and reduced the physician's fee schedule payments. They look at certain reporting mechanisms and other values and decide who is providing a lot of value for the money in the marketplace. Which providers have patients with improved outcomes and reduced costs, and this results in a bonus payment. If you're not receiving a bonus, this means you're not getting paid, and that payment is going to those physicians who are receiving a bonus. This is why it's really important to pay attention to these value-based programs. These incentive programs will be increasing in value over time. So if you aren't currently receiving a bonus, you're going to be losing money year over year. This is where your coding will make a big impact in your payments. As you can see, while HMSA has moved towards payment transformation, the concept is not unique to us. As of July 1st, we'll have a large number of our PCPs involved in some form of payment transformation. Medicare is also shifting their payment format more and more towards focusing on quality as well. By next year, 50% of Medicare payments will be coming from alternative payment models, and 90% of all Medicare payments will have some link to quality. Medicare's budget is zero-sum, and this is how Medicare pays for the value-based programs. Data is collected through the pay-for-performance programs, and the results of these programs are often made public so people can see how providers are doing in these pay-for-performance programs. This can really affect your future. Patients may be shopping around and choose their providers based on these grades. So not only are your payments today affected, your future will also be affected. There are some changes with big impacts that are happening. One of the significant changes that's happening is risk shifting. In our payment transformation program, some providers are already being paid a global payment to manage their patient panel. Integrated practice units are being implemented on the mainland, and this is where you have a team of both clinicians and non-clinicians working together to provide a full range of services to people with the same or similar chronic disease. This team focus is really an efficient way to deliver care to patients. A study at a West German migraine center showed reduced costs of 20% while showing an improvement in patient symptoms by 54% by implementing this type of integrated system. As with payment transformation, you have a global payment and there is a quality component built in. This is something you can expect to see happening with more and more carriers in an effort to control costs and improve patients' health. For instance, we would look at a patient, look at his illness and diagnosis codes, and we'd say this is how much we expect this kind of patient to cost to care for this year, and these are the outcomes we're expecting you to maintain with this patient. And we also have an expectation of patient satisfaction. So there's a lot of quality being built into the program. The need for change has never been greater. According to the Commonwealth Fund scorecard, the U.S. healthcare system is the most expensive in the world. Despite its high cost, it's outperformed by many countries in most performance measures. So in response to this, the Institute of Medicine issued 6 goals that should form the core needs of healthcare. Care should be safe, effective, patient-centered, timely, efficient, and equitable. The Institute for Healthcare Improvement, or IHI, advocates that healthcare reform requires implementation of 3 aims, or the triple aim, which is to improve the healthcare experience, improve population health, and reduce costs. And how do we do this? This is accomplished through effective data, patient care, collaboration, and coordination of care, and that's how we can achieve the triple aim. So how do we survive the transition when medicine is changing so rapidly and changing to a system where CPT codes carry less value and the ICD or diagnosis codes carry so much more value? This is contradictory to the traditional way of thinking where providers are usually more concerned with the billing procedures codes for payment. There are actually several keys to success. Be vigilant and try to qualify for as many bonus payment programs as you can, such as PQRS and CPC+, and also doing well in your pay for quality or your payment transformation measures. One of the keys to success is to optimize your practice margins. And it's also important to maximize your patient volume by including Medicare and Medicaid patients. Data integrity will continue to be important. Is your medical record documentation complete enough, and does it have enough detail to support the code billing? Does your documentation accurately describe your patient's conditions to the highest level of specificity? If you're not coding to the highest level of specificity, you may be missing out on some payments. And operational integration through your electronic health record. Your EHR should be able to support your office. Many EHRs allow you to run reports or will integrate your diagnosis codes when you file your claims, such as adding in the appropriate code for a patient's BMI and blood pressure. We understand that providers just want to take care of their patients. We also realize that there are many administrative burdens that often take time away from actually practicing medicine. In the fee-for-service world, providers aren't paid for diagnostic codes, so many providers in the past did not focus on diagnosis coding. With the implementation of ICD-10, pay for performance changes, and EHR initiatives, diagnosis coding has become increasingly important. And we hear this quite often from providers that they're clinicians, not coders. And it's frustrating for providers to try to keep up with all the changes that require more and more time away from seeing patients. So what's clear to us is that anytime someone is paid based on outcomes, the diagnostic coding matters. And anytime someone is paid for cost savings, such as in our payment transformation program and pay for performance, your diagnostic coding matters. Whenever someone is looking at practice or provider-specific data to evaluate case mix and workload, again, your diagnostic coding is going to matter. So no matter how you look at it, your diagnostic coding is driving everything you do and will result in more accurate payments for your practice. Now, what may not be so clear or readily apparent is the impact of complete and correct coding. It extends far beyond one encounter's medical necessity. It's really what drives evidence-based medicine. Now, I wanted to shift gears a little bit and talk about hypertension for a moment, and we'll focus more on coding for hypertension a little bit later in the presentation. Hypertension is often referred to as the silent killer and affects about 31% of adults in the U.S. Data from 2015 states that in Hawaii we're slightly above the national average with about 32% of adults affected. The CDC states that about 30 million people in the U.S. have diabetes, and that number is growing exponentially each year. So diabetes and hypertension often go together. There's a wealth of information, tools, and data and publications available on the cdc.gov website if you want to get deeper into all of these data numbers. So as you can see here, the prevalence of adults with hypertension is on the rise. Hawaii's numbers are indicated by the circles, and the U.S. is indicated by the squares. So if you look towards the end, 2016, you see there is an uptick in our numbers. There are several risk factors for hypertension, and some are modifiable factors, such as tobacco use, sodium and alcohol intake, and others are not modifiable, such as age, ethnicity, and family history. But all of these will factor into a patient's risk for hypertension. In Hawaii, you can see that it doesn't matter if you're male or female, your ethnicity, or your age. Hypertension does not discriminate. Anyone can be affected by hypertension. However, the prevalence of hypertension is more common in men than women, and it also increases with age. And Asians are more likely to develop hypertension than whites, Hispanics, or Pacific Islanders. Overall, Hawaii ranks 23rd of 51, which is including Washington, D.C. So we're on the upper half of the scale, with 1 being the worst and 51 being the best. Nationally, approximately 8% of the adult population has undiagnosed hypertension, so the actual prevalence in Hawaii may be higher than what's stated. Non-modifiable risk factors for high blood pressure include age, ethnicity, and family history of high blood pressure. The modifiable risk factors include being overweight or obesity will factor in, physical inactivity, tobacco use, stress, a poor diet, and excessive alcohol intake. So even though the data in this chart that you see on this slide is from a few years back, the premise that lifestyle factors greatly affect the incidence of hypertension still holds true. Smoking, lack of physical activity along with weight, alcohol intake, and a diet low in fruits and vegetables are all factors that the patient has within their control. By taking a proactive approach to these factors, they can take steps towards improving and perhaps controlling their hypertension. As you see from this chart, we're doing the right things, and by we, I really mean all of you. We're advising hypertensive patients to take their prescribed medications, exercise, reduce their sodium intake, eat a healthier diet, and reduce their alcohol consumption. So these are the things that we ask you to continue to do when counseling your patients who have been diagnosed with hypertension. Diagnosis codes are not just for submitting on claims for payment. They also are very impactful in public health drives. In 2016, in Hawaii, we had 244 cases reported of hepatitis A as compared to only 6 cases the previous year. And as you can guess, the sharp increase was likely due to certain sushi products. But the bottom line is that we wouldn't have this data if providers didn't properly submit the diagnosis codes for this disease. This will affect education drives, initiatives on a local level, as well as vaccination funding. And it's really interesting to think about how when you submit a code, it can have very far-reaching effects. CMS maintains a database called the Chronic Conditions Data Warehouse. It houses tons of information on chronic diseases, everything from Alzheimer's to diabetes and chronic kidney disease. It shows you how many people in each state are affected, their ages, and which diagnosis codes are applicable to each category. The diagnosis codes help us identify population trends and funding needs. And you can find more information at the website link at the bottom of your screen. Diagnosis coding impacts provider and payer compliance, reimbursement, and performance measures. On a micro level, coding impacts every patient. And on a macro level, coding impacts national policy, funding, and medical research. Let's move on to talk about coding the medical record. The medical record is what your coder draws the codes they bill from. In the ICD-10 Codebook Introduction, CMS states, The importance of complete, consistent documentation in the medical record cannot be overemphasized. Without such documentation, accurate coding cannot be achieved. When a provider is coding or a coder is abstracting a chart, the words written in the chart must be used to select the code for the diagnosis. CMS does not consider a diagnosis code to be appropriate documentation of a diagnosis. A code itself written in the medical record is not a diagnosis. It must be written out in words. Every diagnosis on your claim form must be well documented in your medical record in words, and the words in the chart must be used to select the code for the diagnosis. So just because the provider enters a code into the chart doesn't mean the code is supported by the documentation. Again, the documentation must be in words, and every diagnosis must be documented well to be coded correctly. Codes without a narrative diagnostic descriptions are invisible for coding. Documenting hypertension by writing I-10 in the record does not provide the qualitative information necessary to submit the code I-10 on a claim form. Your coder can't enter this on a claim form, and that's a rule made by CMS. If you document diabetes E10.9, which is a type 1 in your medical record because you consulted the pull-down list on your EMR, and you know the patient has type 1 diabetes, but you didn't further document anything else about the condition, such as whether it's type 1 or type 2, then your coder must code E11.9, which is type 2, regardless that you wrote E10.9, because you documented diabetes without further specifying it was type 1. And this is based on ICD-10 guidelines. Whenever diabetes is not specifically described, it defaults to type 2. And this is why documentation in words is so important. Another problem for coders is cloned list of problems, prescriptions, medical and surgical histories from EMRs. You have a patient that has Huntington's disease listed as a past medical history on a problem list. The coder cannot code this, even though it's a chronic condition. It must be addressed in the current encounter. Even to simply say the patient's Huntington's symptoms are stable, even if the patient is in the office today for hypertension, if the provider documents today's encounter and notates that Huntington's disease is stable, then it can be coded. And this is important because if you only see the patient once this year, this is your only opportunity to document a chronic disease and add this to the patient's RAF score, or risk adjustment factor. If it's a disease listed in their review of chronic conditions list, this again may be your only chance this year to confirm or deny the diagnosis. Medication lists are the same way. There must be a diagnosis described in the current visit. For the most part, coders are not clinicians. In your documentation, you talk about adjustment of a patient's sliding scale of insulin. You say what you're changing it from or to and why you're making the adjustment, but if you don't document the word diabetes, your coder can't code for diabetes. They can only code for long-term use of insulin. Even though it seems obvious by looking at the record that the patient has diabetes, it cannot be coded unless the record specifically has the word diabetes written. Coders cannot make assumptions based on what's in the record. Or if the provider documents that the patient is drinking a case of beer a day, something's happening, but there's documentation that's not being stated. Alcohol use can only be coded if the provider documents some kind of problem, such as alcohol is causing insomnia. Alcohol abuse and alcohol dependence can only be coded if it is specifically documented as such. If the patient record says creatinine of 29, there's really nothing to code. You could guess that the patient has CKD, but if the CKD isn't documented, then you can't code for it. And that would mean a lower risk score for that patient. When we get to code selection, it's really important that the clinician chooses their words very carefully. If you don't choose your words carefully, the ICD will choose them for you. The coder has to take the exact words from documentation and look up that word in the ICD book. One polyp in ICD leads you to a neoplasm code, while another will lead you to an unspecified disorder of an anatomical site. So just looking up the word polyp can take you in several different directions, and your coder can't make any assumptions about what you meant. They can only code what's based on what's been written in your record. And this is why being specific is so important. What happens is sometimes because of statistics, there's a default in the ICD-10 coding. And for instance, this is the case with diabetes. The default is type 2. So if you just say diabetes, it doesn't matter what kind of diabetes your patient has. The guidelines in the book tell us it's going to be type 2 because that's the majority of diabetics. If you just document sinusitis, then your coder has to bill for chronic sinusitis because that's the default. And the same thing with bronchiolitis. It indexes to acute bronchiolitis. Sometimes it works out okay, but other times it's not what you meant or it's not accurately reflecting your patient's condition. So unless you're specific in your documentation, your coder may have to bill for a diagnosis that was not your intention. What can we do to help you with your specificity when choosing your words and documentation? Initially, CMS gave everyone amnesty for the first year after ICD-10 was implemented. They accepted many codes that they normally wouldn't have, such as nonspecific and sometimes erroneous codes. As long as the code was in the right family, the right number of characters, and it was a valid code, they accepted it. Unfortunately, today, amnesty has gone away, and CMS is expecting you to properly use ICD-10 codes. As of October 1st, 2016, CMS is expecting providers to document with specificity and accurately code their claims with as much specificity as possible. You need to code each health encounter to the level of certainty known for that encounter. And of course, you should avoid unspecified ICD-10 codes whenever your documentation supports a more detailed code. If your patient has diabetes and chronic kidney disease, you should not be coding E11.9 because the patient has a kidney complication of diabetes, and that should be reflected in your diabetes code. How can you prevent CMS troubles? Simply by being specific. 80% of problems are caused by 20% of the work performed. So let's look at the top 10 errors in documentation and coding and some easy solutions. History of is always a big one. As a medical professional, you're taught that history of is the past and present health of the patient. However, in ICD-10, history of refers to a patient's past medical condition that is no longer receiving any treatment. But that has the potential for recurrence and therefore may require continued monitoring. There is a big difference in the two definitions. The ICD-10 definition is the definition that CMS uses in audits. Realizing this difference is really important because in risk adjustment, when you're coding a condition that's history of, it doesn't map to any HCCs or hierarchical condition categories, and it doesn't risk adjust. But without the history of these conditions documented, it will definitely map to an HCC. That's why it's really important to distinguish between something that's a current condition and still being treated and something that truly is a past condition. So the solution to this one is pretty simple. Avoid using the phrase history of unless you're documenting a condition that has resolved. Instead, use phrases such as the patient's here for continued care of or an ongoing condition or something in that nature. This will help ensure your claims are being coded correctly and medical necessity is correctly captured for coding. And it'll help to ensure that past or resolved conditions don't get coded. And the next one is causal relationships. For most diseases with causal relationships, the causal relationship must be linked in the documentation. Records submitted should include language from an acceptable physician specialist which establishes a causal link between the disease and the complication. You can't use the word with to connect diseases, such as diabetes with retinopathy. There has to be something else that connects it to show an etiology and a manifestation. And there's a couple of exceptions to this rule. There is a new coding clinic guideline in 2017 that says almost any condition that occurs with diabetes will be connected to diabetes. It doesn't have to be connected in the documentation. If your documentation talks about diabetes on page 2 and neuropathy is mentioned on page 5 of the same encounter, it will be considered diabetic neuropathy. And hypertension is the same way. If the patient has hypertension and the patient has kidney disease, they're linked and should be coded as hypertensive chronic kidney disease. If they have hypertension and heart disease, those are linked and should be coded as hypertensive heart disease. We have causal relationships that are assumed with diabetes and hypertension, as well as heart disease and hypertension. With pregnancy, there's a similar situation, but instead of being causal, it's a complication. So if your patient has the flu while pregnant, it would be considered a complication of pregnancy, and you'd use an obstetrical code that identifies infectious disease as a complication of pregnancy. Hypertension in pregnancy would be coded also as a complication of pregnancy. And there's one exception to this. With diabetes, hypertension, and pregnancy, if the conditions are not causal, the provider must clearly document that the conditions are not related. If the patient's kidney disease is due to diabetes and not to their hypertension, it needs to be clearly stated in the record. Likewise, if the patient has kidney disease that's a congenital condition and not due to diabetes, the provider will need to clearly state that. What can we do to improve documentation? Be sure to use the words due to when there is a definite relationship between diagnoses. For example, the patient has a hip fracture due to secondary bone cancer, due to primary breast cancer. And this will make it crystal clear for your coder. If the patient has pneumonia due to RSV, that would be important to note since there's a specific code for that. Also be sure to document no relationship for diabetes, hypertension, and pregnancy as needed, such as saying unconnected to or no relationship or not related to. This will reduce denials or queries from CMS, and it's a good practice from a medical legal standpoint. It's also for patient care and outcomes. It ensures your coder won't link what should not be linked. Okay, specificity. Not enough information on the condition. It's really important to have qualitative information on patient conditions. Be sure to distinguish between acute and chronic conditions. With leg ulcers, be sure to specify if it's due to diabetes or if it's a pressure ulcer. Be sure to always state pressure ulcers. If the patient has Crohn's disease, make sure you document any complications like bleeding and obstruction, so the proper diagnosis code can be reported. So the solution for specificity is to add those qualitative words to the diagnosis showing your assessment as appropriate. Chronic versus acute, stable or worsening. Note if the condition is resolved, in remission, or if it's an active condition. And of course, be sure to indicate the site and laterality, left or right, and if there's any complications. Specificity helps to more accurately reflect the appropriate level of medical decision-making that was needed for that visit. It can also help reduce denials and queries from CMS. And it'll also help with medical, legal, and patient care outcomes. Okay, the next one is include health status. Does the patient have a stoma, amputation, transplant, paralysis, or an intellectual disability? These are all important facts that affect the patient's overall health and their RAF score, and these should be documented annually. So the solution is make sure if they're an Akamai Advantage patient, review the review of chronic conditions list and any other problem lists that come up in your EHR so you can address all of the chronic conditions your patient has. When you have a patient in front of you, you can notate in the physical exam or HPI that their diabetes is stable, right foot amputation noted, the stoma looks good, etc. This provides a more comprehensive look at the patient's medical conditions, and it may affect your E&M level, and of course, it factors into the patient's RAF score. If there's any conditions which affects a patient's RAF score, then that's a red flag that you should be reviewing those conditions at least once each year. With behavioral health, we see some missing information, especially when it comes to substance abuse diagnoses. Etiology in dementia and manifestations such as wandering or behavioral disturbances are often not notated in the medical record. You'll want to notate use, abuse, or dependence with substance abuse, or if it's in remission, that should also be stated. If there are complications arising from drug use, be sure to link those. If the patient has alcoholism in remission and has liver disease and they're linked, you'd want to document alcoholic liver disease. If the patient is having a psychotic episode related to methamphetamines, be sure that's properly documented and linked. Specify history of or in remission, and be sure to differentiate between the two. For conditions like depression or other behavioral health conditions, notate whether the episode is mild, moderate, or severe. Also be sure to document intellectual disability when it's appropriate. What can you do to improve? Document granularity in the description of chronic mental disease. A lot of patients bring their problems to their PCP because they don't want to see a specialist. Be sure to clearly identify whether the condition is acute or chronic, or describe the situation that may be causing the episode. With behavioral health, documentation is really important because there could be medical legal situations that arise or patient outcomes that could be reliant on your documentation. Be really clear when documenting neoplasms. Unclear documentation leads to errors. Sometimes in the chart, the neoplasms are not clearly identified as primary or secondary. And history of should not be reported if it's an active condition. If the patient has cancer, don't document NED or no evidence of disease. This is a red flag for CMS that the patient has a history of cancer. Active cancer is reported as long as the treatment is ongoing. If surgery is complete and chemo and radiation are complete, then the patient has a history of cancer. Unless the patient has a cancer such as leukemia that goes into remission, you wouldn't classify the cancer as being in remission. Again, document to the highest level of specificity, include whether the cancer is primary or secondary, malignant or benign, or in situ. Only use uncertain behavior for neoplasms that have undergone microscopic examination. Uncertain behavior is not the same as unspecified. Unspecified would be used when the exam results are not back or hadn't been sent out. Uncertain is very specific. Once the pathologist examines it, they determine if it's a certain cell growth, and if they're unable to determine if it will develop into a cancer or something benign. Primarily, medical, legal, and patient care outcomes are a big advantage. Imagine if someone were taking over care for your cancer patient. Your details become exceedingly important if the new provider is to understand your patient's history and provide continuity of care. Everything evolves and changes, and code changes happen a couple of times a year. This means documentation will need to adjust, and CMS comes out with new rules all the time. Something new that recently came out was a code for diabetes with diabetic macular edema resolved following treatment. Having diagnosis codes for a resolved condition is something new, but there have been codes for history of conditions for quite some time, but we haven't really had codes for resolved conditions. Proposed expansion of eligible telehealth services to include dialysis, advanced care planning, and critical care consults for payment by CMS is also a change. They're looking at a proposed diabetes prevention program expansion next year. CMS also published an EHR toolkit last summer for guidance on compliance. Soon it's going to be a requirement. There are lots of tools where you can audit your own system and evaluate your own compliance. Keeping up with all the changes can be challenging, so you may want to consider designating someone in your office to be your compliance person. That person will need to monitor CMS, read the newsletters, evaluate annual CPT, ICD, and HCPCS code changes. This person ensures changes are implemented in the office and providers are informed of the upcoming changes. Having a staff member allows providers to focus on patient care. It also supports compliant and effective practices, and it keeps the providers out of harm's way. Addressing weight issues is not just obesity and morbid obesity, but also malnutrition and cachexia. Reporting BMI is required for PQRS and for our pay-for-quality and payment transformation programs. If a patient's BMI is too high or too low, there should be some discussion with the patient, and that should also be documented in the medical record. We strongly encourage that you check BMI at every encounter and be sure to address the ones that need it. Document changes in weight or BMI, and closer monitoring of BMIs provide opportunities for intervention that can improve outcomes for patients. And of course, just as a reminder, BMI is one of our measures that we do ask providers to document at least once per year. A diagnosis can be reported only when it's explicitly described in the progress note. Coders or auditors cannot infer a diagnosis or refer to a problem list. Be sure to code all documented conditions that coexist at the time of the visit that require or affect patient care or treatment. The solution here is include the qualitative elements with every diagnosis. Address chronic conditions with regularity, and think in ink. If you're thinking it, write it down. Your coder can't connect the dots for you. You need to write it down, such as I'm taking into consideration X and Y, so I'm thinking this. So I'm going to run this test to see if it's this condition or that condition. That shows the medical decision making, and it'll help you with your E&M leveling. Consider how the patient's chronic conditions affect today's chief complaint. Below knee amputation is consideration for a patient with diabetes or contralateral DVT. Be sure to notate any intellectual disability, as that can affect the encounter and patient compliance. The advantage is providers who report diagnoses with a greater level of granularity fare better in PQRI, and their patients may experience better outcomes. Properly documenting thought process may impact your medical decision-making and your E&M level. Okay, focus on documentation. The devil's in the details. The details in the diagnoses matter. CMS stated the importance of consistent Complete documentation in the medical record cannot be overemphasized. Without such documentation, accurate coding cannot be achieved. Your coder cannot code to the highest level of specificity unless the chart is documented to the highest level of specificity. Encounter forms are not acceptable documentation. Problem lists are not acceptable documentation. Lists of meds and scripts in the medical record do not meet medical documentation requirements to show a condition has been addressed. And a list of lab results are not the equivalent of a diagnosis. So we really need to look at changes in the workflow and content. Consider that your documentation should meet the needs of an audience other than yourself. Be thorough and address chronic conditions often. Determine if it makes economic sense for you to perform time-consuming coding, as well as whether it's the best protection for your practice. It's really the best protection for your practice as we move into a payment system that places more weight and emphasis on diagnosis codes. What is risk adjustment? We talk about it a lot. It's a statistical process that takes into account the underlying health status and health spending of the enrollees in an insurance plan when looking at their health care outcomes or health care costs. Risk adjustment is a modern methodology that accounts for known and or discovered health data elements and levels comparisons of wellness among patients. While all risk adjustment models utilize diagnosis codes to determine potential patient-level risk, there are additional elements taken into consideration, including age, gender, socioeconomic status, disability status, insurance status, such as Medicare, Medicaid, or dual eligible, claims data elements such as procedure codes and place of service codes, special patient-specific conditions such as being in hospice or being an ESRD patient. Providers have an opportunity to enhance risk adjustment strategies. Consider for a moment your office's approach. Have you set internal goals and objectives? Are you prepared for patient engagement, provider education, and chart coding while avoiding common causes for low risk scores? Consider this 5-step formula. Step number 1, physical and health assessments. Ensure that you're touching each patient at least once each year. It's important to focus on the population that has unreported chronic conditions that are less likely to go to the doctor on their own. Also, be sure to utilize planned benefits such as the annual wellness visit. Step 2, provider education. Accurate risk scores depend on accurate provider documentation, coding, and billing. You need skilled coders who can engage with providers and office staff. The key to improving risk scores long-term is to have cooperation among each facet of your office. Step 3, data validation. The diagnosis codes submitted on claims form from providers need to be supported in the medical record. There can be insufficient provider documentation to meet coding guidelines, or, alternately, sufficient provider documentation but incorrect coding. Unsubstantiated diagnosis codes could cost significant dollars during an audit as a result of fines or penalties. Preparing in advance of an audit is key to understanding how much risk exists. Step 4 is chart review. Proactive chart reviews will lead to more stable risk adjustment scores with gradual improvement over time. Knowing which patients have chronic conditions is key to a successful retrospective chart review. And step 5, patient outreach. Effectively contacting your patients who do not take it upon themselves to come in to see you regularly is the cornerstone to risk adjustment success. Predictive analytics can be used to identify those patients that may have chronic conditions that have not been seen recently or who have been seen but not diagnosed with certain chronic conditions. An efficient outreach program to connect patients with the right care at the right time will help to build trust and improve patient satisfaction. Okay, Medicare Advantage. This is a program offered by private insurance companies. The Advantage plans are equal to and most times better than traditional or original Medicare. Only those eligible for original Medicare may apply. Out-of-pocket caps on some plans versus original Medicare, where the copay is only 20% without caps. And some other extra benefits include drug, dental, and vision. About 31% of Americans who are eligible for Medicare chose a Medicare Advantage plan last year. And there's numerous competitive plans to choose from. But you want to look at the benefits of those plans based on your personal situation. MAOs are Medicare Advantage organizations. So let's talk about those for just a minute. The amount CMS pays to a Medicare Advantage organization varies for each patient. And how it works is that there's a base payment for each member, and then that payment is risk adjusted based on diagnosis codes that were submitted during the prior calendar year. And demographic factors are also considered when calculating the payment for each member. So this is why we ask that you code all the diagnoses that pertain to that patient each calendar year, because at each January, the slate is wiped clean and we have to start all over. Provider coding traditionally focuses on CPT coding. While we still require you to file claims with CPT codes in payment transformation, we are looking more closely at the diagnosis codes. Each year, the diagnosis list is zeroed out by CMS. So if the patient had an amputation, each year as of January 1st, CMS kind of forgets about that amputation. And this is their way of ensuring the problem is addressed every year. So each January, that slate gets wiped clean. All patients are considered healthy until diagnoses are again reported, ensuring that patients are being treated for the chronic conditions they have. If the condition isn't reported at least once during the year, that condition will essentially fall off of the patient's risk score. Your goal is to report each mapping diagnosis as often as it meets reporting guidelines. If providers don't correctly code or don't code all diagnoses, the Medicare Advantage organization ends up having problems. The amount received by CMS is lowered, and that in turn means payments to providers could be lower. Upcoding your claims will also bring fines, and downcoding brings losses, which is why accurate coding and accurate documentation is extremely important. And of course, a lowered star rating penalizes the Medicare Advantage organization. Does your documentation have meat? Medical necessity is when there's a diagnosis that shows evidence a service was warranted. And we talk about meat all the time. So have you monitored or measured, evaluated, assessed or addressed, or treated a condition? Remember, only one element of meat is required to support a diagnosis. But of course, if you have even 2 or 3 elements, that's even better. To ensure your documentation has meat, you'll need to notate signs, symptoms, disease progression or regression, and that'll show that you're monitoring a condition. To show evaluation of a condition, document test results, medication effectiveness, or response to treatment. Ordering tests, discussion, reviewing records, or counseling shows you're assessing or addressing a condition, and ordering medications, therapies, and other modalities indicates treatment of a condition. In the risk adjustment world, specificity is extremely important because some diagnoses map to an HCC, but other closely related diagnosis codes don't map to any HCCs. For example, atrial fibrillation maps for RA, but dysrhythmia does not. So you wouldn't say cardiac dysrhythmia if it's afibrillation or atrial fibrillation. Don't take shortcuts just to put a code down. Be sure to find the proper, correct code. You wouldn't document bronchitis if the patient has chronic bronchitis. Bronchitis doesn't map to an HCC, but chronic bronchitis and COPD both do. With pneumonia, specify what kind of pneumonia. Even if you just say bacterial pneumonia, that'll map to an HCC. While if you're just documenting pneumonia, that won't map to any HCCs. Okay, star ratings is how CMS measures the Medicare Advantage plan. It evaluates how well the providers are managing preventive services, how they're managing chronic diseases, and care coordination. On the plan side, they look at customer care and member satisfaction and how complaints are handled. All of this contributes to the rating, but providers play a really big role in our star rating, and this is why you often hear from us about reminders about star measures and closing those star gaps. Medical coding of patient encounters is only as good as the underlying medical record documentation. Always review your record to ensure documentation is thorough and accurate, that the conditions are coded to the highest level of specificity, and that there is consistency. Okay, make sure you're on the ball. Engage your clinicians. They can perform accurate capture of primary conditions as well as presenting comorbidities, particularly in more complex cases. Engage the staff and coders to do pre-visit planning, assist with referrals, keep up to date on changes, and submit accurate claims. And adopt technologies. Technology changes rapidly, so electronic health records or other software will help improve your efficiency and accuracy. We found that practices who standardize processes for complete medical record documentation and coding experience minimal disruption to practice flow. Develop internal checkpoints for the most common documentation and coding errors prior to claim or encounter submission. You can utilize tools and resources to identify and remediate incomplete coding, and be sure to review impacts and opportunities to improve clinical documentation and complete code capture. These best practices will help you be more successful. So let's take a quick look at a documentation example. Here we have a 77-year-old female presenting with UTI-like symptoms. She's complaining of fatigue, low energy, and poor appetite. She's 18 months status post for an MI, appears frail with mild malnutrition. She recently lost 23 pounds in 4 months, complains of pain with urination, weakness, and dry, itchy skin. Medical history, patient has type 2 diabetes, CKD secondary to her diabetes, and a below-knee amputation. She also had a UTI 4 months ago. She's continuing her metformin and some Bactrim for the UTI and insured for her malnutrition. And we've also referred her to a couple of specialists. So taking that chart note, we know she has type 2 diabetes and she came in for UTI today. So an office might just quickly code these two conditions to get the claim processed. However, there's much more information in the note that can and should be coded for proper credit on the claim. And by credit, what I mean is we want to know the true status of your patient and how much time and effort you're taking with the complex patient. So for this patient, the claim should be submitted with a diagnosis code for each condition that was either monitored, evaluated, assessed, or treated. Proper coding would result in diagnosis codes for type 2 diabetes with renal manifestations, stage 2 CKD, malnutrition, prior MI, and an amputation. Her UTI doesn't risk adjust, but being that this was her chief complaint today, of course, you're going to code that condition on your claim. Looking at this, you can clearly see what a difference it can make when all conditions are properly reported on a claim. If you just submitted she has type 2 diabetes and her urinary tract infection, that would only risk adjust to 1 HCC. If it was properly coded, you would end up having 5 hierarchical condition categories, and that's going to make a huge difference in her risk score. Okay, so we talked a little bit about hypertension earlier. Now let's take a more in-depth look at coding for hypertension. So I-10, my favorite ICD-10 code because it's so easy to remember. Essential primary hypertension. So this is when blood pressure is 140/90 or higher. Blood pressure that's 120/80 or lower is normal, and anything between the 120 and 139 or the 80 and 89 for your bottom number is considered pre-hypertension. Hypertension has 6 major categories. I-11, hypertensive heart disease, and there's also some additional codes to indicate whether that's with or without heart failure. I-12 is hypertensive chronic kidney disease, and additional codes to indicate the stage of the chronic kidney disease. I-13 for hypertensive heart and chronic kidney disease, and also additional codes to indicate heart failure and the stage of the CKD. And you have I-15 for secondary hypertension, with additional codes to indicate when the hypertension is secondary to another condition. And we have I-16 for hypertensive crisis. These are fairly new codes, and it has additional codes for urgency or an emergency. So in the big picture, hypertension has a limited number of ICD-10 codes to choose from. There's really only 9 codes for primary hypertension and 5 codes for secondary hypertension. This makes the task of coding for hypertension relatively simple, at least compared to some of the other ICD-10 complexities. Another positive change in ICD-10 is that the new code set drops the previous reference to benign and malignant hypertension. But of course, nothing is easy in ICD-10, and there are several things you need to be aware of before we dig into the codes themselves. For example, the hypertensive disease codes in ICD-10 exclude several conditions: hypertension complicating pregnancy, neonatal hypertension, and primary pulmonary hypertension, and primary and secondary hypertension involving vessels of the brain or eye. Post-procedural hypertension is also excluded from the secondary hypertension codes. ICD-10 only uses a single code for individuals who meet criteria for hypertension and do not have comorbid heart or kidney disease, and that's the I-10, or Essential Primary Hypertension Code. This code includes high blood pressure, but does not include elevated blood pressure without a diagnosis of hypertension. That would fall under the ICD-10 code R03.0. If a patient has progressed from elevated blood pressure to a formal diagnosis of hypertension, a good documentation practice would be to include the reason for progressing the formal diagnosis. Similarly, a single mildly elevated blood pressure reading should be coded with the R03.0 until a formal diagnosis is established. Although various sources define hypertension slightly differently, the provider should document elevated systolic pressure over 140 or diastolic pressure above 90 with at least 2 readings on separate office visits. There are slight variations of this for older individuals and for individuals with readings obtained through ambulatory blood pressure monitoring. From a documentation standpoint, it is only important that the provider clearly document the basis for a newly established diagnosis. When an individual has hypertension and heart disease, it's up to the provider to determine whether there is a causal relationship stated or implied. This relationship determination is spelled out in the official guidelines for coding and reporting. In ICD-10, this is narrowed to only 2 base codes: I-11.0 for hypertensive heart disease with heart failure, and I-11.9, which is hypertensive heart disease without heart failure. The ICD-10 manual does not list the required documentation for hypertensive heart disease. It is recommended, however, that the provider document the basis for the diagnosis, whether that's an exam or electrocardiogram, etc., at least the first time the diagnosis is made for the patient. It's not uncommon for patients with long-standing hypertension to develop some cardiac changes, but to code I-11.9 instead of just I-10, the provider needs to document the support for doing so. When you code hypertension with heart failure, you are required to also code the type of heart failure from the I-50 series, whether that's left ventricle failure, combined systolic and dystolic heart failure, diastolic, or whether it's unspecified. So be sure you got all your ducks in a row when you're using this code. Unlike hypertension and heart disease, where the provider must determine whether a causal relationship exists, if the patient has hypertension and develops chronic kidney disease, ICD-10 presumes a cause and effect relationship and classifies the condition as hypertensive chronic kidney disease. However, if that chronic kidney disease came first, then the combination falls into the secondary hypertension codes. ICD-10 also requires specifying the stage of the chronic kidney disease to properly code the condition. Note that ICD-10 differentiates stage 5 from end-stage renal disease by the need for chronic dialysis. ICD-10 requires first using an I-12 code for the combined diagnosis of hypertension and chronic kidney disease. For I-12.0 and 12.9, that's hypertensive chronic kidney disease with a stage. The two codes require an additional N18 code to identify the stage of kidney disease, with documentation typically referencing the most recent eGFR results. If the patient has all three conditions, hypertension, heart disease, and chronic kidney disease, then you need to document the relationship between the hypertension and heart disease, but you can assume the causal relationship between the hypertension and the chronic kidney disease. These codes for the three disease combination are numerically arranged by the degree of their chronic kidney disease rather than the presence or absence of heart failure. All of the three combination codes you see here require additional coding from the N18 series to identify the stage of their kidney disease. The three combination codes that include heart failure also require additional coding from the I-50 series to specify the type and acuity of the failure. All of the hypertension codes require an additional ICD-10 code if the patient is a current or former tobacco user. So whether it's nicotine dependence, cigarettes, chewing tobacco, or other products, you need to notate that. And each of these four categories has a required sixth character to indicate whether the condition is uncomplicated, in remission, with withdrawal, or with other specified nicotine-induced disorder, or an unspecified nicotine-induced disorder. There may be some patients in the primary care setting who have hypertension secondary to other disease states. In these cases, providers cannot use the hypertension ICD-10 codes discussed above. Instead, use the following codes. So I-15.0 for renovascular hypertension, 0.1 for hypertension secondary to other renal disorders, 0.2 for endocrine disorders, 0.8 for other secondary hypertension, and I-15.9 for secondary hypertension unspecified. The 5 secondary hypertension codes require that you also code the underlying condition. ICD-10 typically permits either the underlying condition or the secondary hypertension code to be listed first, depending on the reason for the patient encounter. The only exception to this is I-15.8 for other secondary hypertension. Because this is an other code, the other condition must be coded first. There are two hierarchical condition categories associated with hypertension. The first one is HCC 85 for congestive heart failure, and the risk adjustment factor is 0.368. Anytime your claim is coded with I-11.0, I-13.0, or I-13.2, it'll fall into this category. And 0.368 is a pretty significant adjustment to their risk factor. So if this is the case, be sure to include documentation for that. The second HCC is 136 for chronic kidney disease stage 5. And this has a RAF score of 0.224, which is also a pretty significant adjustment to their risk score. So anytime these codes seen here are reported, they will fall into the HCC category of 136. Okay, so this slide here is just a quick chart for your reference for reporting blood pressure measurements on your claim form. These are the Category 2 codes you can enter to your claim, or you could also input the blood pressure readings via supplemental data in COSIVA. I get asked pretty often what these codes are, so that's why I have this chart here for your reference. You can cut that out and put it next to your computer. Some common errors happening with blood pressure measurements. A blood pressure cuff that's too large will falsely give low readings, while an overly small cuff will provide readings that are falsely high. The most practical way to safely and properly size a blood pressure cuff is to pick a cuff that covers about 2/3 of the distance between your patient's elbow and shoulder. To accurately assess blood flow in an extremity, influences of gravity must be eliminated. So the standard reference level for measurement of blood pressure by any technique, whether it's direct or indirect, is at the level of the heart. When using a cuff, the arm or leg where the cuff is applied must be at mid-heart level. Measuring blood pressure in an extremity positioned above the heart level will provide a falsely low blood pressure, whereas falsely high readings will be obtained whenever a limb is positioned below the patient's heart level. The standard for blood pressure cuff placement is the upper arm using a cuff on bare skin with a stethoscope placed at the elbow fold over the brachial artery. The patient should be sitting with the arm supported at mid-heart level, legs uncrossed, and not talking. Talking during the measurement could result in a higher systolic reading, so try not to engage your patient in conversation and try not to let them use any hand gestures. Reading over clothing could also result in a higher systolic reading. The same holds true for if the patient has a full bladder, has very recently used tobacco, or has white coat syndrome. Those all also often result in a higher reading. The last thing I want to leave you with today is a list of the top coding errors we see in risk adjustment. Medicare Advantage health plans are reimbursed based on the beneficiary's chronic condition. So submitting an inaccurate diagnosis or a diagnosis resulting in a different hierarchical condition category is a compliance risk. Any change in the HCC could mean you are receiving too much or too little revenue. Either way, the code would not be validated and would be considered a discrepancy. So there are opportunities for you to capture a more appropriate HCC code. Consider this list of top 10 coding errors for risk adjustment. The record does not contain a legible signature with a credential. The EHR was unauthenticated or not electronically signed. The highest degree of specificity was not assigned. The most precise ICD-10 code to fully explain the narrative description of the symptom or diagnosis in the medical chart, or a discrepancy was found between the diagnosis codes being billed versus the actual written description in the medical record. If the record indicates depression, not otherwise specified, but the diagnosis code written on the encounter document is major depression, then your codes don't match and they map to different HCC categories. The diagnosis code and the description should mirror each other. And your documentation does not indicate meet or that the diagnoses are being monitored, evaluated, assessed, addressed, or treated. When it comes to cancer, if your status of cancer is unclear and treatment is not documented, you need to improve in that area. Chronic conditions such as hepatitis or renal insufficiency not being documented as chronic is a common error. Lack of specificity, such as an unspecified arrhythmia, is coded rather than the specific type of arrhythmia. Or chronic conditions or status codes that aren't documented in the medical record at least once per year. And last one is a link or cause relationship is missing for a diabetic complication, or there's a failure to report a mandatory manifestation code. Okay, so that's the end of the formal presentation, and we're going to go ahead and try to answer your questions now. We have about 20 minutes left, so I'm going to try my best to get through all of the questions. If I don't get through them, we will get back to you directly with an answer. So the first question is, where is the acronym MEET adopted from? I'm not sure if you mean who created it, but the letters in MEET stand for M for monitor, E for evaluate, A for assess or address, and T for treat. So each condition that you're documenting in the medical record, you should be at least monitoring, evaluating, assessing, or treating each condition. And for each condition, you want to have as much documentation relating to MEET as possible. Okay, the question is, how is the history of BKA appropriate for a visit for a UTI? Although in the notes it was addressed, where is the medical necessity for reporting? So you're correct that the patient came in primarily for her UTI on the visit. But what if you only see that patient once this year? You're not going to have any other opportunity to address her amputation. So that's why in that example, we took every condition notated in the record and coded it, because sometimes you don't know if the patient is going to come back, especially if it's not a patient who comes in regularly for a chronic condition that needs constant monitoring. Okay, so in January, does all risk scores go to 0? And the answer to this is yes. CMS kind of forgets everything you documented throughout the year and starts again from 0. So each year you need to code every condition again. So that's kind of the same as our review of chronic conditions. Once you've gone through the entire list of patients with chronic conditions by December 31st, in January you need to start all over again. So this is more of a comment. Sometimes insurance does not cover a well check every year. This is true. For Medicare patients, they have an annual wellness visit benefit, and some of our commercial plans do have benefits for a yearly checkup or a physical exam, but you would need to refer back to plan benefits. Not every plan allows a well check every year. Okay, so this comment is, the person is doing the coding themselves, but with all the new changes, could we recommend someone to help update with the new changes? Can you trust your current billing company to update the new coding rules? Or do you need to hire someone else to do that? So first, I need to say that we cannot recommend anyone because we cannot show favorability to one company over another. However, we do work with a lot of billing companies, and from our experience, they do their best to keep up to date and keep their computer systems up to date. It's really up to you if you feel you need to go to an outside source to maybe audit your billing company or what your billing company is submitting on your behalf. And for that same person, we are recording the webinar, and it usually takes about 2 weeks for us to post it. It will be posted in the Provider Resource Center under the training link. So is the word meet now replacing the word SOAP? Meet is similar to SOAP, so your subjective, objective, but providers are still using SOAP as far as when they're writing their SOAP notes. Meet is more of the documentation checklist. So do you want to be sure that if you're documenting a condition that in your wording you're either somehow monitoring, evaluating, assessing, or treating the condition. If there's a discrepancy between code description and what the physician documents, will the default code suffice? Okay, so you really have to go with what the physician documents, and using that documentation, choose the code from there. As I mentioned earlier, you can't really make an assumption or infer a code based on what's written, because when it comes to an audit, they're going to look back at what the physician documented. Yeah, I've had actually kind of a lot of requests for pediatricians. I'm going to ask that all of you who are requesting pediatric training, if you could notate on your evaluation form more specifically what you're looking for. I can include that in the upcoming quarterly trainings, especially if you have specific diseases that you want me to address. Okay, so in the example of the lady with diabetes, you list a number of HCC categories, but a number of these do not, I'm not sure I understand, do not translate to a number. So in the example I showed, sorry, just let me grab that for a minute. Okay, so it says CKD 2 and 3 no value, but 4 and 5 do. So the reference I was looking at, stage 2 chronic kidney disease does map to hierarchical condition category 125, and in turn, that condition category does affect the patient's risk score. So in a sense, you can look at it that HMSA gets credit for these, but in the long term, the physician offices are the ones who's going to end up getting credit, or in payment transformation, reimbursement is going to be based on the complexity of your patient. So that's why we're asking you to be really cognizant of all the codes you're submitting and be sure to submit all the diagnosis codes that are appropriate for your patient. Okay, this one says only one element of meat must be met in order for us to code something off of the past history. So when you're documenting a current condition, I'm getting a little confused with your past history, but if the person has a condition that you're monitoring, so if it's a past history, you wouldn't necessarily be monitoring it, but if it's something like diabetes and you're monitoring their A1C levels, you're going to document just that. You know, if they came in for a cold today, you don't have to put a whole history, and just one element of the meat needs to be met in order to code for it. Okay, sorry, to clarify, yes, you can still write your SOAP notes and use meat as your checklist. You are correct in that. Okay, so this one is, if the physician documents depression, default is F32.9, major depressive disorder, single episode, unspecified, which is the default code. The documented diagnosis in the chart does not state major depression. Will this be a problem? I don't think it's a problem because the description of your code is single episode. So in that case, it should be okay, but I would have to double check. I'm not an auditor, so I'd have to double check on that and get back to you.
Okay.
Okay, I'm not sure what is involved in a non-Medicare annual physical well visit. I was told that I cannot address complaints at that time, otherwise insurance will not pay for it. Can you please clarify? So the annual wellness visit is generally just that, a wellness visit. Most times providers don't like to combine an E&M with the annual wellness visit, although I think it is possible if they say they had their annual wellness visit scheduled and now they're coming in for another condition that happens to be at the same time. I'm pretty sure you could just use a modifier 25 on your E&M and bill the annual wellness visit at the same time. But your documentation would definitely need to show a clear distinction between that E&M visit's purpose and the difference between that and the wellness visit. Then we have one asking for a printout of today's webinar. If you did not receive a copy of today's slide deck, we can go ahead and send that out to you. And the slides will also be posted in the Provider Resource Center once we get the recording finalized. So this one is, we cannot require our patients to do a yearly for our measures if it's not a benefit of their plan. Can HMSA do something about that? The parents get very upset that we require this and then bill them for it. You're correct, not every plan has wellness visits, especially for children after, I believe, age 6. And even for adults, not all plans have an annual wellness type visit benefit. As their PCP, I know it's really difficult. We are requiring a lot of measures be met for payment transformation as well as in the Pay for Quality program. But if you can kind of look at it as preventive measurement and maybe explain that to your patients, they may be more willing to come in. Unfortunately, having an annual exam benefit is something that the employer groups negotiate whether or not to have that in their plan benefits. So part of that is out of our hands, and it's not, an ACA benefit, unfortunately. So what if the doctor only specifies the diagnosis, hypertension in his documentation, and no other manifestations or additional diagnosis? Can you then use the I-10 code? The answer to that is yes, as long as he's writing out the word hypertension and not just putting in what the blood pressure reading was numerically or, using a blood pressure number with an arrow up, then yes, hypertension will suffice for an ICD-10 code documentation. Okay, there are a few questions specific to coding, and unfortunately I don't have the ICD-10 book in front of me, so I couldn't really answer your coding questions without referring back to the book. So those questions, I'll have to get back to you individually. As far as choreo, grabbing diagnosis from the active list, I don't have a lot of information yet on how choreo is going to work with the active list, but as far as submitting your claims, especially for CMS, you are still going to have to code every condition every year to get credited for it. Okay, so that's, we're right at about 2 o'clock, and like I said, if I didn't get to your question, I will get back to you specifically. If you have a question you didn't get a chance to type it in, please go ahead and enter that on your evaluation form. Be sure to fax or email the evaluation back to us. We really appreciate your feedback and any suggestions that you may have for future webinars. We will definitely take that into consideration. Anytime you have any questions that you need help with, go ahead and email us at psinquiries@hmsa.com. Thank you. I know this was a really long webinar today, but thank you for spending some time with us, and have a great day.